Hi, everybody. Welcome to AUK COVID for March 25th, which is, I believe, our 26th webinar in this series, which actually is amazing. And there's still lots to talk about with respect to COVID and its prevention in our workplaces. We are really excited about our lineup today, and so grateful that you can join us to participate in the conversation and ask questions. We're starting with Dr. Tara Moriarty, who's going to speak about reality check, excess and missing deaths and their implications for prevention. She's an infectious disease researcher and associate professor at the University of Toronto in the faculties of dentistry and medicine. She's been part of and still contributes to several COVID-19 responses, including two organizations that she co-founded, the COVID-19 Resources Canada and Science Up First. Before COVID, her research lab studied and still studies Lyme disease and bloodborne infections, and she's the former scientific director of the Canadian Lyme Disease Research Network. She's always worked on responding to Lyme disease misinformation, which is a lot of what she's also doing in response to COVID. The organization she leads, which is the COVID-19 Resources Canada, is funded by the Public Health Agency of Canada to provide Canadians with Zoom-based access to volunteer scientists to talk about vaccines and COVID. That's an exciting thing we hope we can learn more about. She's also the lead author, team lead for the Royal Society of Canada's report on COVID-19 mortality in Canada. And they're currently preparing an update covering the first wave of COVID. And she will share the link later on to the Zoom session so that we can all follow all the information further. So without any further ado, Tara, we'll turn it over to you. Thanks.
Thank you very, very much for the invitation to be here. I'm really looking forward to meeting all of you and talking further. But a big part of why I really want to be here is I and others have been working on ways to help people living in Canada understand their COVID risk as we go forward, and as it's clear that people are assuming most of the risk and responsibility for responding to risk with COVID. So I'm actually going to be I'll be talking about deaths because I always think about deaths and severe outcomes of COVID. But I'm actually going to be talking about methods that I've been trying to develop to help us understand where we currently are, how many infections are happening, where they're going, and what the risk of that is for all of us individually and on a population level. So really what we're trying to do is develop basically a dashboard that we can put up on the website for COVID-19 Resources Canada that would give metrics from different parts of Canada that are different than the ones that you can get through the Public Health Agency of Canada and others, but that will help people to make decisions about risk. And I'm going to show you some of the ways that I've tried to contextualize that. And I'm really interested in feedback and thoughts. And I'm good at the math and the numbers, but presenting things in a way that people will understand and will be useful is very much not my expertise. So I'm really looking forward to your help with that and your engagement with this so that I can learn more and we can be more useful for people. All right, and just in case you are on Twitter, my handle on Twitter is Moriarty Lab, and usually on Fridays, I won't be today, but usually on somewhere between Friday and Sunday, I post a weekly update on what current risk levels are for severe outcomes during the Omicron wave in Canada, if you're interested in following that. And I usually pin my weekly update to my profile if you'd like to look at that. Okay. There we go. All right, so today I'll be talking a little bit about exactly what the future estimated COVID-19 mortality is still expected in Canada compared to the top 10 causes of death. So I'll be trying to talk about the big numbers, and I could talk in some detail about how I try to estimate them, but I'm going to try to focus on the take-homes. Oh, I'm going to talk about what the estimated total undetected and unreported Omicron deaths may be to date, because I'm trying to estimate that right now, because we won't have excess mortality data for at least a year for this wave in Canada. So I'm trying to understand what may be happening at the moment. I'll be talking about ways to estimate the total percentage of the population, that's already being infected with Omicron, as well as the estimated percentage of people 40 and older who are susceptible to future Omicron infection. And this is the largest risk group. I mean, there are many risk groups, but focusing on people 40 and older is a way to estimate where the largest population risk group is. And then I'll be talking a bit about what tools people need, what tools everyday people need to make decisions, what tools supervisors and employers and people who are immune compromised and people who are caregivers and people who are themselves at risk, how they can judge how safe it is, and how they should modify or make decisions accordingly. So I'm going to share resources that I've been assembling right now, mainly with Google Sheets and other spreadsheets that I can share publicly, but which will live on our website at some point. But resources where you can go and look up at any time what the personal and population risk might be. And I'll be talking about ways to try to estimate the actual current infection trends, and ways to try to understand these relative to the risk of mortality from other diseases. So link for this presentation, I've done this in Google Slides. And once I've finished with this presentation, I'll share the link to this to the presentation in the chat if the moderators haven't done this already. And within the presentation, I have links that you can go to look things up, and these are updated every week on Fridays usually, or over the weekend. But this is a summary image that comes from some of these data. And this takes the future estimated COVID-19 deaths in Canada, assuming that the remainder of the population that has not already been infected with Omicron is infected in the next 12 months. And this expresses or shows what that expected future mortality would be compared to the top 10 causes of death in Canada. So you can see that we can still expect from Omicron that it will be the number 3 killer in Canada after cancer and heart disease over the coming year, if the remainder of the population is infected and if we don't try to prevent those infections. It's currently higher than accidents, including drug deaths, cerebrovascular disease, chronic lower respiratory diseases. You can read all of these: diabetes, flu and pneumonia, Alzheimer's, suicide, kidney disease. And at the bottom, I've provided influenza alone, because you often hear the narrative that COVID-19, and especially now Omicron, is no worse than the flu. And that actually may be, I mean, it's about the flu, maybe about twice as severe in terms of mortality. That's still, when considering how many of us are vaccinated. Without vaccination, it's more severe than influenza. But I'm providing influenza as a comparator, because you often hear people say, oh, it's just the flu. The problem is the flu itself is quite serious, and only a small percentage of us every year are ever infected with the flu. So normally the deaths that we would experience in Canada, there would be maybe about 3,400 deaths from influenza each year. And you can see that the expected future mortality for COVID-19 for Omicron is about 10 times higher than that. So it's still a very serious problem in Canada. And I and others are extremely concerned that this isn't being communicated clearly to people, and that a lot of the responsibility for protecting themselves has devolved onto people individually, but we're not providing information that gives people a way to understand their true risk. So a lot of what I'm working on right now is trying to work around that and say, this is what, this is what it looks like. If you're in this age group, maybe it's not a concern for you and you're fully vaccinated. But on a population level, this is still going to be possibly the number 3 killer in Canada for the next year. And of course, we're also learning that reinfections are happening and that previous infection is not reducing the risk of severe outcomes like hospitalization. There's a large study that just came out of the Veterans Administration healthcare system in the US that found that reinfections are common now and that the severity is not particularly reduced if people have been infected before. So that's extremely concerning that essentially what may be happening is that if we don't prevent people from getting infected, that we essentially the infection is going to keep working its way through susceptible populations, and the people who survive or don't become extremely ill the first time are the ones who are going to be left, and it's quite worrisome. All right, and this is just a quick look since I was going to talk about excess mortality. So this is the extra or untimely deaths that occur on top of the number of deaths that you would normally expect. I was going to talk about this in this session, but I'm not going to talk about it extensively. And we certainly don't have the data for this from the Omicron wave, and we won't have very complete data for quite a while. But I've been trying to estimate using methods that we and others use to estimate unreported, undetected deaths from COVID-19. I'm trying to estimate at this point how many deaths may not have been reported or missed in Canada so far in the Omicron wave. And it's quite high. It looks like we may have the highest under-detection, under-reporting rate during the Omicron wave of any wave to date. And it's particularly bad in Ontario, where at this point it looks like there may be about 3,200 deaths that haven't been reported or that haven't been detected. And what we found in previous waves is that the majority of these likely COVID deaths that go undetected appear to correspond to people in their 60s and 70s who are community dwelling and who are likely not in the long-term care age group, people 80 and older, and who may not be accessing hospitals and/or may be dying suddenly at home without those deaths without testing having been done. And in some provinces like Quebec largely captures all of its COVID-19 deaths and has since the beginning of the epidemic. They do things like post-mortem testing so that if someone dies at home and they haven't had a COVID test, but it looks like COVID, smells like, there's a likelihood it was COVID or they're living with someone who had COVID, they will do post-mortem testing. They'll take a sample from the person after they die and they will report that. But most other provinces don't do that. So if you haven't been able to access testing and you die at home, you will not be reported as a COVID death because you're not tested, even if it does look like it was COVID. So there are a lot of problems with the way different provinces capture and report COVID deaths, and a lot are simply missed because Canada in general tests far under tests compared to most OECD countries. We test a lot less, with the exception of a couple of prairie provinces in Quebec, but the other large provinces in the country test 2 to 4 and sometimes almost in some periods almost 10 times less than most OECD countries. So we do have an under-testing problem in Canada. All right, so I'm going to explain a little bit later how I get to these guesstimates, essentially, about how many of us have been infected with Omicron to date. I'll explain it, but what I will let you know is that I've started sharing some of these on Twitter, and colleagues of mine who work in different research agencies and public health in different provinces have privately reached out to me to say that these data are matching fairly well to internal studies that they're doing with seroprevalence, where they're trying to estimate what percentage of the population has been infected so far. So they're not perfect. We need seroprevalence data as well, but those likely still won't come out for another month or two. And we do need to have some kind of method to estimate roughly where we may be right now. So you can see from this graph that right now, or at least up until March 3rd, which is what this graph shows, about a quarter of the Canadian population has likely been infected. Somewhere between 20% and a third of Canadians have been infected since the beginning of December. In Ontario, where we are, it's somewhere between, it's about 20%. It could be as high as 30% of us have been infected. But that means there are still 2/3 of us who haven't been. And one of the major concerns is that a lot of these early infections with Omicron in the first wave of it have likely been younger people because a lot of older people or people who are more at risk have successfully evaded or avoided being infected, or they've had third doses, for example, that have really reduce the risk of infection from Omicron, but those doses are currently waning at the percent of about 2% loss of protection per week. And we're already seeing in Ontario data an effect of waning of third doses, which is likely what is at least partly driving the wave that is starting now, which I'll show you more data for in a moment. All right, so using these estimates of how many people have been infected and using things like age-specific third dose uptake rates in each province, and using some math to estimate the percentage of people 40 and older who haven't been infected yet, we can roughly estimate what percentage of people 40 and older are still susceptible to future Omicron infections. And this is as of the end of February. So you can see that in Canada, 50%, somewhere between 40 and 60% of us, I'm 50, are still susceptible and likely haven't contracted Omicron infections. And if you look down at Ontario, that number is actually higher. And that's partly because Ontario appears to have had a lower level of population infection with Omicron than a number of other provinces. So Ontario is in there with Nova Scotia, BC. It's a bit less than Quebec. It's sort of it is less than Quebec. It's getting into the same range. But we are different than a number of other places that have had a lot more infections. So for example, in Alberta, it looks like somewhere around 41% of the population's already been infected. Same with Manitoba, Saskatchewan's up in that range too. PEI, which has been really difficult to estimate, is going through an enormous wave right now, or it has started. The uncertainty with this is quite large because PEI doesn't do a lot of PCR testing. They're mainly using rapid antigen tests. And similarly for the north, where there's a lot of use of rapid antigen tests, it looks like a high percentage of the population may be infected there too. But we're going to know more about this over time with seroprevalence studies. But Ontario and Nova Scotia and BC and a little bit Quebec are down at the lower end of the range in terms of how many people have likely been infected so far. And this is why, for example, Ontario and BC have the largest proportion of people 40 and older who are likely still susceptible. That number is a fair bit lower for Quebec because Quebec has much higher vaccination uptake rates among people 40 and older, especially people 70 and older, than we see in BC and in Ontario, where vaccination rates in older age groups are not great compared to the rest of the country, certainly in the over 70s and 80s. All right, so it's clear that we still have a really big problem. We can expect I mean, I'm talking about deaths, but we can expect a lot of future hospitalizations, ICU admissions, although that usually affects younger people more. People over 80 don't end up in ICU most of the time. Some people in their 70s do. But we're certainly looking at a lot of future deaths, hospitalizations, and we don't know with Omicron what the risk is for long COVID, which is prolonged symptoms that last past the original severe or acute infection. But if it's like, if it's like the susceptibility to long COVID that we've seen for previous strains, then we could be looking at 20% of 20% of the general population, maybe 10% of the vaccinated population who are exposed or who contract COVID-19, who may end up having prolonged symptoms. And obviously, if you're infecting huge proportions of your population, as we've seen with the estimates I've just shown, that is potentially a lot of future disability. And the other thing that's important for people to understand is that before Omicron, maybe at most 15% of the entire Canadian population had ever been infected before Omicron with any of the previous variants. And so everything that we experienced that brought us to our knees was with 15% of us being infected over time. Now with Omicron, we've just seen, 30% of the entire population get infected in a few months. And we likely still have about 2/3 of the Canadian population that is yet to be infected. So you can see why this is an enormous problem, and also why, if long COVID proves to be an issue for people infected with Omicron, as it has for previous strains, then we could be seeing a lot of short-term and long-term disability resulting, and a lot of people whose health will be reduced quite a bit by these infections. And since you work in occupational health, I know that a lot of occupational health is working with people like my mom and dad, for example, who both had and have dementia, working with people to figure out ways to maximize quality of life and function. And we all know how under-resourced that system is, and how overloaded that system is, and how many people need that kind of support, and how many did before COVID. And going forward, it's pretty concerning how this will, how people will be supported both medically and in terms of occupational health. All right, so in these slides, I've provided a couple of links that you can go and click on. Like I said, they're still just Google Sheets right now, because mainly I spend all my time trying to do the estimates, but we're formally going to start posting them on our website so that they are a little bit more professional. And we're writing up some of the papers associated with this so that people can really understand the methods that we've used. So you can, for example, look up what your or someone else's individual or personal risk is if they get infected. So for example, if we click on here, this is what the spreadsheet looks like. It's the individual risk of hospitalization, ICU admission, and death based on the number of vaccine doses that people have and their age group. So this may help people to understand what their own personal relative risk is when they're trying to assess this. Obviously, it doesn't include specific comorbidities. It's much harder to do those estimates, and age is probably as detailed as we can get. But hopefully, this is still something that can help people understand. What their risk is depending on their age and vaccination status. And then we also maintain information that's useful for looking at population risk. So I have a spreadsheet that I've been maintaining for quite a long time that sort of tries to add up what all the total expected future severe outcomes would be if everyone is infected. And this is fairly complex, but this I calculate this by looking at age-specific vaccination rates, infection fatality rates, hospitalization rates, and ICU admission rates, the effect of vaccines, the number of doses of vaccines people have had, and also subtracting the deaths that have already occurred in a particular region and age group. So it's a whole bunch of different moving parts, and this is a way to try to put all that information together to say roughly what are we looking at if the rest of the population were infected. So you can see that there's a column, so it goes by province and territory, and it tells you how many unvaccinated deaths, hospitalizations, and ICU admissions we can still expect. And then it calculates those as the rates per 100,000. It also estimates the future breakthrough. So in people who are vaccinated, people who have severe breakthrough infections that result in death, hospitalization, ICU admission, and then the totals for those numbers, which you can see in bright yellow here, and then those expressed per 100,000 people. And you can see if you look at this that Ontario is actually quite high up this list, partly because we haven't had as many deaths and severe outcomes per capita as other provinces. Less of us seem to have been infected so far, but we also have a problem in Ontario with this gap in vaccination in older people that is not as bad in other provinces. So for example, Quebec, PEI, and Newfoundland and Labrador have the highest vaccination rates in the country among older people. And you can see that Quebec, for example, has a considerably lower expected future total deaths per 100,000 for that reason. And then the rest of this just provides information like how many of those deaths do we expect to be reported, because that's going to be different than what the actual deaths probably are. Information you might find useful in talking to people, like how many lives has COVID-19 vaccination likely saved to date in Canada? How many deaths have been caused by COVID vaccines? Information like the total expected annual influenza deaths by region. And then also things like what the estimated financial costs are of hospitalizations and ICU admissions for expected future severe outcomes. And all of the sources and all of this are provided at the bottom of this sheet, but they're all from, the Public Health Agency of Canada, Canadian Institute for Health Information, places like that. So this may be useful both in understanding what could still come, but in also communicating with people. If you need to look up and say, listen, we would expect, and it hasn't actually been reported yet, but out of the entire Canadian population of 38.5 million people, we would only expect one death from a COVID-19 vaccine statistically. And that would have been from the AstraZeneca vaccine, actually, which has been discontinued in the groups that are at risk. So it does help to be able to provide this information, or say, listen, Canada normally has 3,300 flu deaths, but in fact, we're looking at, a total of nearly 35,000 COVID-19 deaths if the remainder of the population is infected. Okay, and the other thing is that I've tried to express these numbers as in a different way, because not everyone relates to the numbers the way I've presented them there. And so this is trying to tell people, this is the population risk, but to say, okay, if you live in Alberta, well, let's say if you live in Ontario, based on our vaccination rates, everything else that goes into that spreadsheet that I linked or showed you recently. If you live in Ontario, one out of 149 people who will be infected with Omicron, who haven't already been infected, will be expected to be hospitalized, one of every 1,230 future infections will result in ICU admission, and one of every 895 people infected will die. So that's a way to look at the population risk in each province. So anyway, those links are there. So I do a Wednesday night session where I and other scientists do a Wednesday night session where we talk to anyone in Canada, a bilingual session, anyone in Canada who wants to talk to scientists about the current data, about vaccines, anything like that. We'll share the webpage that you can use to find those sessions. If you're interested in the data and how it's calculated, we're actually going to start doing a Tuesday night session that's just for that. For people who are interested in understanding the ins and outs of the data. And we'll provide that information and it can be shared with you. If you would like to attend, you can be anonymous, you can be, it's confidential. The whole point is for people to have, be able to talk and think about these topics and so that scientists are there supporting anyone in Canada who has these questions and wants to directly talk to someone about it. All right. So as part of this work, I've also been trying to estimate current actual infections, and we all know from watching case numbers that it's almost impossible to understand what's going on, and it's certainly very hard to, if we're waiting for hospitalizations, that's a fairly problematic. By the time you're seeing a big increase in hospitalizations, you already have a lot of cases. So this isn't entirely done yet, but we've almost solved most aspects of it. We're trying to estimate the current actual infections in each province on a day-by-day basis. And the way we do this is we take advantage of the fact that historically Quebec has identified and reported all or almost all, at least 95% of their estimated COVID-19 deaths. So they have an amazing, fast reporting, accurate, complete COVID death reporting system, and they really prioritize it. No other province in the country is doing this very well except Quebec. But we know what the estimated infection fatality rate would be for Quebec as a whole, what for Omicron. And we knew that at the beginning, and we know Quebec's deaths. So what we could do is we can back estimate from the deaths that Quebec reports on a daily basis. We can back estimate and say 2 weeks before how many infections was that, and by sort of normalizing the data for other provinces by basically comparing the test positivity rate, which you see in blue, in other provinces to the test positivity rate in Quebec on exactly the same day, we can then say this is probably how many infections there were in other provinces. So this is complicated. I won't talk about it too much, but we're basically looking at different parameters. So looking at the test positivity rate in dark blue, the reported cases in light blue, the reported tests in gray, and the reported deaths, which are in this dashed red line. And then from those deaths, we calculate how many infections there likely were. And that's the dark black line that you see here. And when we move the reported deaths over and overlay it on top of the estimated actual infections for Quebec, it's very close, as you would expect. If you look at Ontario, for example, you can see that in Quebec maintained its testing at a higher rate than its test positivity rate for until very, very recently. And what's happening now in Quebec and in a number of provinces is that cases are really starting to take off. So the test positivity rate in Quebec and other provinces is going back up. So because Quebec did this, it didn't it largely it didn't reduce its testing faster than its test positivity rate, which means that it was still always being performed at a higher level than the test positivity rate. But in Ontario and quite a few provinces, you see that the drop in testing happened considerably before the drop in test positivity rate, and then at best just follow along with the test positivity rate. And this results in under detection of a lot of cases, which is partly why Ontario is missing so many expected COVID-19 deaths. Anyway, so we do this, and you can see that, for example, right now the black line, which is the estimated actual infections, is really trending back up in Ontario and in Quebec. These little blips are just because I haven't updated data from the last 2 days, so you can just ignore them. they're incomplete graphs. But you could see that this upward trend in cases actually started around the second week of February. But if you looked just at reported cases, it didn't look like that. It looked like they were declining, and that was because the testing rate continued to decline. We did see an increase in test positivity happening towards the end of February, which I and a lot of people were pointing out and were concerned about. But it's clear that we are well into quite a wave again now, from the looks of it. But if we'd actually been monitoring estimated actual infections, we would have seen these trends long ago. So that's partly what we're trying to do, is say, where are we likely? This may not be perfect, but it still is better than what we have. And we all need this kind of information. So using that, this is a graph of showing what the estimated actual infections per 100,000 people have been over the Omicron wave for different provinces. And you could see, so PEI is still really high up here, and we're not really, PEI in the north, it's hard because a lot of their testing isn't PCRs, so they're not quite reporting the same thing. But clearly they both are having big waves right now. And you can see that Newfoundland and Labrador has really been going up. New Brunswick has been really going up. There's Nova Scotia starting. And right now, Ontario and Alberta and BC are down towards the bottom in terms of estimated actual infections. This is only till February 24th. And as you can see from the previous graph, it really starts increasing after that. But even if we present these numbers, what do they mean, right? I mean, we'd say what does it mean that Ontario has 101 estimated actual infections per 100,000 people on February 24th? What do I do with that information? So we've tried to translate that and say, knowing the infection fatality rates that we would expect for each province based on its vaccination rates, age structures, everything else, how many COVID deaths, Omicron deaths, would we expect from this? And then, and because even the number of deaths is something that we don't always relate to as a pure number, we've been trying to express this in terms of deaths from other causes that people might relate to more. So this graph is basically identical to this one, except what we're doing is saying how many expected daily COVID-19 deaths will result from these infections shown here for every one expected daily flu death. And so you can see that, for example, let's leave PEI. Oh, sorry, I have these a little bit out of date. But you can see that, for example, in New Brunswick right now, the risk on February 24th was, so basically the population level risk of the number of infections that were occurring meant that New Brunswick on that date would expect 41 times more deaths from COVID-19 a couple of weeks later than they would expect from influenza. So it's a way to say that New Brunswick on February 24th, it was 41 times worse than the flu. And I don't know if this actually works for people. So for me, that works, but for a lot of people, I'm not sure if that's a helpful metric to show on a daily basis. And this is something that you actually might really have insight into in a way that could really help me to help us figure out how to do this. So this is just a work in progress. This isn't public yet, but you can go to the spreadsheet and look. We're sort of trying to set up something like a current COVID-19 risk meter with more current data than some of what I just showed you, where it wouldn't look like this. It would look nicer than this, where we would say, okay, what's your current daily COVID-19 mortality risk in your province compared to the expected daily deaths from flu and top 10 causes of death in Canada? So what we thought was, so for example, here's Ontario on March 3rd, the current daily COVID-19 mortality risk was 15 times higher than the flu. And then 2 weeks before that, it was 16 times higher. So there's been a drop in there was a drop in the risk from 2 weeks before March 3rd to March 3rd. So, does this change show people that it's going down, and say yes, but in Ontario, your risk is still 15 times higher than death from flu? And I don't know whether this is useful, and you may be able to help me understand that. And then we've also expressed this relative to other major forms of disease. So you can see that in Ontario, on March 3rd, COVID-19 was likely to cause 14 times more daily deaths than kidney disease or any of the number of diseases. And that on March 3rd, COVID-19 was third only to heart disease and cancer in Ontario in terms of risk of mortality within the next couple of weeks. So again, this is just something I'm messing around with right now. These numbers are not current, so this is my working sheet to try to show people what it could look like. So these are not something that you want to cite at this point, but you can go and have a look at it. And then beneath, I've also tried to express the expected future total COVID-19 mortality compared to the expected annual mortality from the top 10 causes of death in Canada, just to show that, for example, in Ontario, the deaths we would likely still expect are 12 times higher than the flu. From Omicron, 11 times higher than kidney disease annual mortality, 10 times higher than suicide, etc. Moving along so that you can see that it's likely that in Ontario in the next year, assuming everyone is infected in that year, that COVID-19 will be the number 3 killer after heart disease and cancer. So I don't know whether, and I think there are different people this information will be useful for. I'm not sure whether this is going to be effective, but I'm guessing that this might be something that's useful for you in the work you do. The other thing that we're working on estimating is trying to help people show how masks and different kinds of masks reduce their personal risk of severe outcomes from COVID-19 and even long COVID. We're going to try to estimate in a rough kind of, ballpark way. And also estimate the sort of high level effects of different kinds of masks on the population risk of future severe outcomes. And we're also trying to estimate very roughly what the personal risks and population risks might be of long COVID, knowing what we do about long COVID with previous strains, pre-Omicron, but it is important at least to try to estimate how many people this could be and how big this problem could be before we have specific numbers of percentage of people who'd be expected to contract long COVID from Omicron itself, because we're always playing catch up. And at some point we have to say, how bad could this problem be, both for me personally, but also for the healthcare system, for Canadian society in general, for just the workforce, for quality of life, for even for lifespan and future needs for long-term support and for disability support. And with that, I know that it's a lot of information. I know it's a lot of numbers. I'm really good at numbers. I'm not always good at putting them in context. So if you didn't quite get it, just let me know and I will try to explain better. And otherwise, I'm really looking forward to any kind of thoughts, suggestions, comments, anything you can do to help us make this more useful for you and for anyone living in Canada who really needs help making decisions right now. And with that, I will stop sharing and see if there are any questions.
Thanks a lot, Tara. It was a lot of information and so interesting. I have been following your weekly Twitter threads and I find
Yeah.
them fascinating. It's easier, well, some people don't find that, I guess, on the phone to go back and forth and get that sense of the way the curves shift. And I do think it is, I mean, thank goodness for Quebec, I guess we have to
Yes.
say, in
Oh,
terms
yeah.
of if we'd be
Oh,
pretty
yeah.
lost if they weren't doing such a
Yeah.
conscientious job
Yeah.
of documenting cases and deaths and that kind of thing. So I
Yeah.
haven't actually seen in the chat, although John, you did put in a reference with respect to Wang et al. Did you want to speak to that at all?
I was just curious if you've seen that paper and what you think of it. It gave Canada a pretty good rating compared to some other countries. It was a systematic analysis published in Lancet, so we figured
Mhm.
should have some degree of respectability or peer
Yes.
review anyway.
Yeah, yes, exactly. So that is about the same range that we have found as well. That so Canada in general does a little bit better because Quebec basically gets all of their deaths. Outside of Quebec, we probably on average miss about 50% of our COVID deaths. Ontario is a bit better. Ontario misses about 30 to 40% of its COVID deaths, misses or doesn't report. And in some cases in Ontario, that's actually because the province uh, doesn't report, or like, for example, recently 400 Omicron deaths were removed from the reported numbers. And some of that stuff is because some provinces change what they report, and that contributes to why their total reported deaths are lower than excess mortality. And we'll know with Omicron, as we get excess mortality data. But yeah, the ratio that you're showing there is about what we have found as well in the past. And it's important for people to know that this is actually pretty normal for even for high income countries. There are a lot of reasons why COVID deaths might be missed. A big one is that if people don't have access to testing and they don't know that they are positive for COVID, that they may not be reported as a COVID death. And lots of people who die of COVID have other things like diabetes, other conditions where if they weren't tested, even if the COVID made, for example, the diabetes worse, which we know is a problem with COVID, that it might be thought that they had died, of diabetes, for example, and instead of both diabetes and COVID.
Yeah, I just thought I'd throw in Denmark because we seem to
Yeah,
be talking about what they're doing, and
yeah. Although you know how high their excess mortality is right now, eh?
yeah.
Yeah,
For
I have
Denmark,
a,
just
I
it's really
actually
going
I
up.
have a slide where I'm going to show that. So our
Yeah,
two
yeah,
presentations will
yes,
merge.
yes.
that's
Perfect.
great.
That's great.
Yeah, I think that Aaron made a comment about how eye-opening the presentation is, and I think that, so just to clarify, so we're an occupational health organization that's more focused on the health and safety in workplaces.
Yes.
So I guess that's, how do we translate this aside from, oh, we're in a wave already, and oh, the wave's going up, and oh, it's a fatal disease for many, many people. I guess we have been living with it for 2 years, and we know the changing policies are affecting workplaces across Ontario right now. And all the people that are on this call are going to work every day, and many of them have to go to places where the mask mandate may have been dropped, or it might
Yeah.
be voluntary and other pressures. So I don't know. And I really appreciate your the knowledge translation and trying
Yeah.
to bring knowledge to people. So I don't know if you have any comments about workplaces, and then I'm also interested in the grant too to do the weekly
Yeah, so we'll
talks.
share,
That's
I'll
really
I'll share the link to that. We've been doing that since the beginning of January of last year. we do a lot of work with organizations too, workplaces, others, where we do special sessions, and on whatever time, on at the convenience of the people there, and some scientists and some healthcare professionals show up, and we help answer questions. And that is, I'll provide the link to it, but that is available to anyone, including you, at any place you work. We're there all the time. We have a large team of volunteers who this is their way that they can contribute to society and at large. But yeah, so these numbers are ways to try to. The problem right now, and I guess the problem with Omicron in some ways, is the silence or the fog, right? Where we don't really quite know what's happening. We don't really quite know how bad it's been, how bad it could be. Everyone's hoping it's going to be better. But even at, like, for example, the expected infection fatality rate for Canada as a whole, because of how much vaccination we have, is about 0.1%. So about 0.1% of people who are infected will die. That seems like a pretty low number, but if you infect 38 million people, that is not a small amount of mortality. And I guess, so, I mean, I personally am very concerned about the masks. I think that we have quite good evidence that masks reduce personal risk and population risk considerably. And that if you're talking about N95 type respirators, that protection is probably as good as a vaccine right now. The vaccines, the problem, I think they're very, very important. But I think the problem in terms of requiring vaccination as a mandate outside of healthcare settings and others is that even though they reduce transmission and infection considerably compared to not being vaccinated, it's less now than it was before Omicron. And the effect also wanes. So it's gray now. It's not as black and white as it was. So, the vaccines are still going to prevent, even at their worst, they're still going to prevent 30 to 40% of infections, and unvaccinated people are considerably more likely to transmit than unvaccinated people, or than vaccinated people. But the masks, I cannot understand why the mask mandates have been removed in public places and workplaces. Especially when you have reduced protection from vaccines against infection with Omicron, which is a hallmark of this strain, you need your masks even more. And we haven't in many workplaces made the adjustments that we need to protect air quality and others. So I think by doing this, I think there's a real need to push back against the relaxation of mask mandates. I think they're really poorly informed, but that's what part of these numbers are trying to say. Like, listen, we're still going to have a lot of severe outcomes in Canada. It does matter. And we need to do what we can to prevent it or slow it so that more people can get Paxlovid, for example, or, so that the trials of the Omicron vaccine will be done. And there are reasons to slow this down and prevent all of us from getting infected.
Yeah.
Anyway, but
Thanks.
we have numbers to make that argument.
Yeah, no, so we appreciate that. And you're able to stay until 3, are you?
Yes, absolutely. Yeah.
Great. So, because I see Aaron did ask, or Aaron commented on how interesting that, and Marianne asked about other tools that might estimate risk based on ventilation levels. But I think, if you don't mind, maybe we'll take that question later. So because John and Kevin may actually talk about some tools as well, and that's something maybe you could think about. So